Hello, everyone. My name is Mike. I'm a physical therapist and your host of the Health Me podcast. Thanks for tuning in, and remember to leave a like and subscribe so you don't miss any updates. During this week's episode, we sit down with an orthopedic surgeon motivated and dedicated to changing healthcare for the better. As a way to begin, our guest will be discussing how he has successfully implemented opioid-sparing and opioid-free surgeries in the midst of a growing crisis here in the United States. And today, we're going to be learning what it was like to implement such a miraculous endeavor. A major part of his success with this surgery comes down to setting expectations and reviewing every hand that goes into the pot of a patient's knee surgery. Our discussion covers the importance of these expectations prior to surgery and review what the process was like from start to finish. More broadly, we cover why the opioid crisis seems to be local to the United States and how other factors such as anxiety, depression, and preconceived beliefs all play a vital role prior to surgery. More about our guest, he is also a co-founder of the platform called Doc Social, a digital platform that allows healthcare professionals to connect, learn, and teach. In addition, he has also been voted on LinkedIn's top 10 most influential voices 2 years in a row. He's extremely dedicated to changing healthcare for the better and certainly motivates me to be better every day, and it was really an honor to have him on the podcast this week. As always, links for our guest as well as the Health Me to Health You portion of the podcast will be below. Here's my conversation with Dr. Vinod Dasa. Dr. Dasa, thank you so much for coming on the podcast today. It's always great to interview a fellow Buffalo graduate.
Thanks.
Well, you have many accolades and have dedicated your professional career to changing healthcare for the better. During this process, you've worked, taught, and collaborated with many healthcare providers to achieve this goal. So I think a great place to start today would ask you, what would you say you've learned about healthcare providers, having collaborated with so many of them along your journey?
I think, the healthcare providers that I've worked with are all extremely committed to patient care. And part of the challenge is we have to start thinking bigger and broader than that because healthcare is changing so quickly. And so I think that's where a lot of the providers I've worked with are struggling. I think to be able to kind of start think more holistically, we have to kind of focus on the patient in the exam room, in the operating room. But if we expect to remain relevant, we've got to be at the table for a lot of these other discussions that are happening. And I think that's what I've noticed is, we're not necessarily plugged in to be having these conversations outside of just simple, clinical care.
Yeah, and I found people can kind of find themselves in these like rabbit holes where they just get stuck with what they're doing, and then outside of work, they're kind of just dealing with family life, and they kind of get in this. I wouldn't even say it's a rut, but they're just trying to manage everything all at once, and it can be certainly overwhelming. At least I felt that. I don't know if you felt that as well.
Yeah, I mean, again, it's a challenge, right? Because you stay in your comfort zone and you're just doing what while everything else is kind of passing you by, and then all of a sudden you look up and you think, what the heck just happened? And so, whether it's reimbursements or changing, types of clinical care, things like that. So I think it's important to kind of just, have a global perspective of what's going on and how you can remain relevant.
And I know for me, a lot of the exchanges that I've had through this podcast has started to dictate my actions. And I was wondering if a lot of the exchanges that you've had has also changed the way you've done things in your clinical practice, as well as just your outlook of how healthcare should be changing.
Yeah, I mean, obviously, working and learning from your peers is extremely important in terms of, developing new techniques and things like that. And what are the pain points, whether you innovate or you're an entrepreneur doing research, having those, conversations and understanding, who's doing what and what are the challenges they're facing, are extremely important. So, that is how I figured out a lot of the, things that I'm doing right now. And it's working with my peers, whether it's anesthesia, and I say, hey, I want to try to get here in terms of my outcomes, how do we get there? And then, partnering with them and then talking to other physicians, what have they've done, or nurses or therapists. And yeah, so I think in when I say peers, I mean globally, because I work, extremely closely with our physical therapists here. and they've helped me achieve, a lot of the outcomes that we're seeing. So it's kind of a broad group of stakeholders to engage.
And I know you've really focused in on this area of collaborating with other physicians by creating a social platform. But today I wanted to kind of get into first where you began to change healthcare. And I think one area that you work heavily in is this opioid sparing, or at least this opioid free surgeries. And perhaps describe which surgeries you've been working with to achieve this goal and trying to get patients away from opioids, so to speak.
Yeah, so the kind of the main surgery is around knee replacements, and so arguably it's probably one of the most painful surgeries that we do in all of healthcare. Whether it's gallbladder, hysterectomies, or hips and knees, probably knee replacement is among the most painful. And so I started kind of down this path probably about 5, 6 years ago, and started adopting, different techniques, different protocols, different innovations to kind of get to this point where, we just published a paper, I think a couple months ago, where coming back from COVID, I kind of flipped the switch. I decided, let's go ahead and let's start doing these surgeries without any opiates after surgery. And we'd been building to that. It's not like we were just prescribing all these crazy high opiates and all of a sudden stop. So we've been slowly kind of bringing its use down. And then, kind of COVID helped me hit that reset button when we came back. And we looked at the first group of patients coming out of COVID where we stopped prescribing opiates to see how we were doing. And 85% of our patients who were opiate naive going into surgery, not patients that were on opiates going into surgery, but the ones that were opiate naive going into surgery, 85% only need Tylenol and NSAIDs, after their knee replacement. Completely, from the moment they hit the parking lot from the hospital to their recovery. So we were able to eliminate opiate use in a huge number of our patients. And so, but that was a culmination of a lot of hard work, working with a lot of different folks, looking at different innovations that I can bring in to kind of get there. And so we've developed kind of this outpatient, opiate-free, enhanced recovery model. And so we're seeing a lot of our patients really benefit from that.
And so many people are getting knee replacements now. It's vital to so many people. I'm assuming, because once you start working at larger numbers, the effect that you can have in that manner and the magnitude that you can have is going to grow more and more. And I can imagine that what are the numbers looking like? I guess, what are you, did it start off slow, or did you implement like large scale change immediately?
We pretty much all comers, we flipped that switch, right out of the gate. So all comers, obviously, certain patients, let's say patients that were on opiates going into surgery, it takes a while to kind of unwind that. So, those are kind of the patients that require a lot more work. So, but we try, and I think we've done a pretty good job, even in those patients, reducing their usage.
Well, before we get into the opioid side of things, I kind of wanted to highlight just like exactly what a knee replacement is. I know everyone understands that you're getting your knee replaced, but I think even patients sometimes when they get the knee replacement, they're like, they did what to my knee? Exactly. Like, what do you mean they did that? I'm like, yeah, well, this is actually what they did. So maybe just describe exactly what a knee replacement is, and then perhaps some of the most common questions that you get with knee replacements.
Yeah. So one of I think, especially on my patients, when I explain it, the preconceived notion is actually we're chopping and chopping and then sticking a new knee, literally a new knee between the femur bone and the tibia bone. And so everyone's got this huge fear of almost like a big tumor surgery. That's what we do during tumor surgeries, not that we would replace a knee like that. So really what a knee replacement is, and so first let's back up. We got to know what arthritis is, because typically we're doing a knee replacement for arthritis.
Hmm.
So arthritis is wearing away the cartilage at the end of the bone. So if you think back to Thanksgiving, you snap open the turkey joint, you see that smooth, white, shiny stuff. Imagine I took a fork and started scraping it away. So that's arthritis. And so what a knee replacement is a surgery where we simply trim away that arthritis from the end of the bone, and we replace it with a smooth metal and plastic cap that fits on the end of the bone. And so it's really, we're removing, maybe 10 millimeters of that arthritic surface just from the end of the bone. And then we put that cap on. And so that's effectively what a knee replacement is. And so it's almost like a resurfacing procedure, not a true, chop and then take the whole knee out and put a whole new knee in. It's more that we're just resurfacing and taking the old tread off the tire and putting kind of a new rubber, if you will, back on that tire.
And now, do you need to be completely down to the without the rubber, or down to like how bad does your knee have to be in order for you to get a knee replacement?
Yeah. So
I've
you
seen,
want you so we're seeing tread, right?
yeah.
And so the rubber's gone and we're seeing metal underneath the rubber. And that's when patients come to us for a knee replacement. Just like when the rubber's wearing out in your tire, you may not realize it until the tire starts going duh, 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 and then you look and see, you're like, oh, whoa, I didn't realize all that rubber had worn off. And now I'm down to, staring at steel or metal. Same idea. That's what happens in the arthritis process. Patients don't necessarily feel that cartilage wearing out, and all of a sudden, all this pain and stiffness and these things slowly start gradually coming on board, and then they come and see me. So a lot of patients are surprised that they're bone on bone. This is something that goes on for years and years. It doesn't just pop up, over a month. And so it tells you it's just a very slow process, and it just takes time for patients to slowly kind of get to a point where they come in to see us.
Well, what's your opinion on when patients become symptomatic? Because I've seen patients who they get the MRI and they're bone on bone, but they don't really have knee pain. Maybe they came in, they're like, oh, I tweaked my knee. I just want to make sure things are going okay. And then I got an image and it turns out I do have really bad knee osteoarthritis, but I had no idea. I guess, when do you think that line is crossed, or why do you think that line is crossed to the point of when a patient becomes symptomatic with arthritis?
Yeah, so it's a great question. I had that same conversation this morning with my resident about what are the pain generators and what causes pain. So if you think about what causes pain anywhere for most joints, there are two main drivers. So first is the bone underneath the cartilage, right? Because cartilage actually has no nerve endings. And then you've got the capsule or the lining of the joint. So in the knee, the what we call the synovium, and that lining has a lot of nerve endings. And so either one of those two structures need to be irritated to have pain. And so when patients develop arthritis, either enough cartilage is worn out where the bone underneath is starting to feel that pressure and those forces, and that causes the pain, or you've got a lot of inflammation in the knee, and that's causing the pain. So if you marry those two together and the cartilage is worn out to the point where you're having pain along with the inflammation, that's when we kind of start. Patients are symptomatic enough that they need a knee replacement. Now, there are, to your point, a lot of patients who have severe arthritis, at least radiographically on X-ray, but yet barely have any symptoms. And we're scratching our heads trying to figure out, are you a candidate for a knee replacement or not? On X-ray you are, but you yourself aren't really feeling that much discomfort. So really, and I don't have an answer to this. Are you a candidate for a knee replacement? And I don't, and it's hard, when patients ask, should I have a knee replacement, yet they barely have any pain, but yet it's bone on bone. So then you have to start understanding the patient, kind of where they are and how it's affecting their life and those kinds of things to really give them some good advice about, whether or not they should move forward.
Another part of this is just the idea of pain, because perhaps, you described this when it gets down to a point where you're activating those nerve endings. But another part of it is I've had patients who come in and it seems like they're going through a difficult part in their life and they start experiencing pain. And do you deal with any like the psychosomatic issues or onset of pain? And do you feel like it's a contributor to the intensity of knee pain prior to surgery?
Yeah, actually, so there is a fair amount of research, and we're working on a couple of those papers looking at anxiety, depression, and those kinds of things, and how they link up with pain. And we know that patients with depression and anxiety and other mental health concerns definitely experience more pain and more disability, both before surgery in the arthritis realm, and then also afterwards. And so it definitely plays a role in how you perceive pain and how you handle it.
And do you think that will be a potential future dictation or dictator of whether a patient will get the surgery or not? Because if a patient has a lot of anxiety and they're going into this knee surgery thinking it's going to be the end all be all, but it's going to be this new pain that they're going to have a relationship with, do you think that might be a dictator of whether they're going to get the surgery or not? Or you think we're a little ways away from that?
No, I don't think we would ever withhold surgery. I think we just have to explain to the patient and do a good job of having the patient understand, what the surgery is about. And if you use that logic, then there are all kinds of risk factors that lead to less than optimal outcomes, right? Smoking, obesity, depression, anxiety. I can go on and on and on. So do we say now, we put out a paper about 4 or 5 years ago that marital status, right? If you're single versus married patients had better outcomes, right? Because they had that social support. So we're going to say patients that are single aren't going to get knee replacements because their outcomes are not as good compared to patients that are married.
Yeah.
Yeah, that's impractical, right? So, we've got to be able to deliver care to our patients. There's never going to be the perfect patient that's going to be, meet all the criteria. So, no one's perfect, right? You're not perfect. I'm not perfect. So, we just got to do the best job we can, given the imperfections that we all have. And so that segues into kind of this challenge that we're facing, where we get into bundle payments and we're starting to be analyzed in terms of our outcomes, and different patients have different risk in terms of developing, complications and things. And so who do we withhold surgery from? Who do we not? And who gets to judge? Who gets to decide, right? Am I the judge and jury and say, no, you can't have surgery. Sorry, you're going to be on Percocets for the rest of your life.
Yeah.
Right?
It's an incredibly challenging point. And I'm assuming a lot of these patients are just in a very vulnerable state, and you want to make the bad decision for them because you're almost playing kind of God at that point.
Absolutely. So let's say, for example, I've got a patient that smokes and has a BMI of 42, right? And we know those two factors have increased complication risks. Injections aren't working, physical therapy, nothing's working, right? They're candidate for knee replacement. So we can say stop smoking and lose the weight. Number one, how practical is that? And number two, what does the patient do in the meantime? Too bad, right? And so, yeah, we are making these really life and death decisions to a certain extent. So does that patient then turn to their primary care doctor and get narcotics then? Because I'm unwilling to accept that risk as a surgeon. So these are challenges and dilemmas that we're facing today. I mean, we have surgeons turning away patients with those two simple parameters today in hospitals. And so what do we do? So what is our role? It's a challenging situation right now.
And it's certainly in orthopedics, I mean, it continues to change, right? Even my role as a physical therapist continues to change, just of, who's the right person you should be seeing at this moment in time. And have you had any struggles trying to manage patients in that regard? I know you're probably mostly seeing surgical candidates at this point, but have you, had to improve your skills in trying to manage, like, well, you're not the right patient for me, like this, you need to be seeing somebody else?
Yeah, I don't know. I don't think I've really ever, unless it's a personality conflict where,
Okay.
we're just not on the same page and we're just not clicking. No, I don't think I've really turned a patient away because of some clinical parameter that I was uncomfortable with. It not, I'm sure there are surgeons that are uncomfortable dealing with more complex situations, but I haven't necessarily had to worry about that.
Well, we've been talking about kind of the secondary or tertiary factors that go into knee replacements, and part of this post-op pain management is the opioid. That opioid, people have been using opioids to help with pain management. And again, you've gone away from this approach to do opioid free, or at least minimize how much opioids you use. Maybe for people who don't understand exactly what opioids are, people kind of have heard about the opioid crisis before and how these drugs particularly work on people, but perhaps for those that are unaware, what are opioids and what is the magnitude of their power?
Yeah, so opioids are a class of medications or a class of drugs that stimulate certain receptors called immune receptors. There's a bunch of them, and they alleviate pain, but they can also have a euphoric effect in some patients. So narcotics considered a gateway potentially to stronger potential abusive medications like heroin and fentanyl and things like that. So we use them routinely for managing pain and pain control. And there are different formulations. Some of the generic version you may have heard of hydrocodone or oxycodone. These are kind of the more classic generic ones, but the brand names are Lortab or Percocet, and they're extremely powerful medications and can lead to addiction. And we're seeing I'm going to guess your audience probably is pretty familiar with the fact that we've got an opioid epidemic in the US, and we're seeing significant abuse of these medications from teenagers all the way through to kind of elderly patients or adults. And so, it's a challenge because we were brought up as physicians probably about 15, 20 years ago to think that, pain was the fifth vital sign and we need to manage it basically to zero. And so we were historically, as a profession, prescribing opiates like it was candy, leading to diversion and massive amounts of addiction, because it doesn't take much to get some patients who are sensitive stuck and dependent on these drugs. And so we have to kind of unwind that. These medications are extremely powerful and dangerous.
And do you believe that this crisis or epidemic is an inclination or maybe a measure of perhaps suffering in the US as a whole? Or do you believe that people perhaps have just a misconception on how to manage pain and what the idea of managing pain more broadly? I mean, it would appear that if there's continues to be an epidemic, it can't all be just like people are taking these drugs and all of a sudden they just go down this immediate pathway, right? And I'm wondering, do you think it's a good metric of like suffering in the country, or do you feel like just people have a misconception of pain management?
Well, so if we look internationally, you would think that there would be the same issue with across all developed countries, right? Whether it's Europe or what have you. And you're not seeing this level of dependence and addiction outside of the US. When you talk to folks in other countries, we are unique in that. So then, what does that speak to then? Well, is it other countries just are better at managing pain, like they're using different surgical techniques and so they don't have that pain, or patient expectations are that you're not going to be completely pain-free? Yeah, you may have 4 out of 5, 10 out of 10 pain, but it will get better. We're not trying to get to 1 or 0. 4 or 5 is acceptable. Like that's okay, right? So I think it's our expectations, it's our interpretation of pain, it's what we've been trained to think. Are we more sensitive to pain here in the US than in Germany or some other country? I doubt it. I think our biology is probably pretty much the same. Are physicians in Germany doing surgery that so differently that their patients don't have pain than the way we're doing a knee replacement, for example? I don't think so. The technique is fairly standardized. So, so why is it that here in the US we're having such a struggle with this, whereas other countries they're not? And so I don't think anyone has a great answer to it, but I think part of it is cultural. I think part of it's expectations.
Absolutely. And I try to do that with my patients as well. As when patients come in, they're always expecting 0 out of 10 pain. And especially post knee replacement, they're like, I was expecting to, get this knee replacement and then have no pain whatsoever, like 2 weeks after surgery. And I was like, you're in for a long road if that's what your expectations were prior to surgery.
Yeah, exactly. But for those patients, do we have the ability to get there for a certain number of patients where, yeah, we can actually get your pain maybe to a 2 or a 1? And that's the point with our opiate-free protocol that we developed, was we actually can get you there, right? If we put a bunch of different things together and we have good teamwork and we have the patient expectation at the right level, like I said, 85% of patients only needed Tylenol, right? They can go get opiates if they need it. They can go to the emergency room, they go to the primary care doc, they could call me and I'll prescribe it if they need it, but they didn't. So we can do it. It's just a matter of wanting to get there.
And when does this protocol begin, and what does it entail, and what does it look like?
So it starts right at day 1 when I talk to the patient about considering surgery and wanting to do surgery. And that patient education and that engagement and setting the expectations are extremely, extremely important. And then, other components are getting the team to row along with you, whether it's my MA in the office, the pre-op nurses, the physical therapists that run our joint camp, the family members, the literature that you give the patient, right? All of that has to be in sync, because, I give an example. When I started doing outpatient total knee replacements back in 2013, so a while back, almost 10 years ago. And to get there required teamwork, right? Because I give this example: if the valet attendant that's going to park your car, or whoever at the hospital parks your car way over there, and the patient says, "Why are you parking over there?" He's like, "Oh, because you're going to be here for at least 3 or 4 days. You get a knee replacement, right?" Guess what? They're going to say 3 or 4 days, even though I told them it's an outpatient surgery, right? So it's as simple as that, as all, and I could spend an hour with my patient talking about outpatient total knee replacement. This is what we're going to do. The nurses, my MA, everybody. But that one person tells them you're staying 3 days. Guess what? They're staying 3 days, right? So same idea. It requires a team effort to really work together to deliver that consistent narrative, that consistent message to the patient that this is what you should expect. This is what's probably going to happen. Obviously, there are outliers, there are exceptions, but in general, this is how it's going to be. And if everyone repeats that and it's consistent, then all of a sudden now you start getting the results that you want.
Even the valet, that's interesting. I never would have thought that the valet would play such a critical role in the process of rehab or surgery and so on.
It introduces doubt, right? You have a discordant message. And so they're going to revert to kind of, all right, well, what you, and not that they're a voice of authority when it comes to a knee replacement, but anything that is not in sync, right, places doubt and confusion. And then the default is, well, we're going to stay 3 days.
Expectations are huge for sure. And I don't want to divert too away from the idea of opioids, because I think one thing that's interesting is before, you described the history of opioids where it was that they, doctors had this idea of getting absolute zero pain. But opioids are effective and they are good at decreasing pain. And so like, is there a line between effective use and perhaps abuse for these pills? And should doctors just be thinking about getting rid of them entirely? Because I've kind of seen a little bit of that. So I just wanted to get your opinion on that.
Yeah, no, there's definitely a role for this, right? I mean, there are patients that have legitimate pain. The question is, do we need to prescribe 80 or 5?
Right.
And that's got to be patient specific. Right now we have a cookie cutter approach. Everyone gets 20 or 30 or 5, right? It's just a very non-specific way of handling it. We need better ways to figure out, all right, this patient who's got all these risks associated with them, that this medical history and the surgery is going to take this long and it's this complicated or this easy or whatever. We need to take all that data, build it together, and have a formula where it says, all right, you get 6 Percocet 5s, right? That should work for you. And this patient over here, so it's precision medicine, it's individualized medicine, where we can craft a kind of game plan that's unique to that patient. So not everyone gets 5, not everyone gets 50. And we design a game plan specific to them. We are not at that level of sophistication yet. I hope someday with AI and technology and all these other things, we're going to be able to kind of crunch all of this data and then hopefully develop a game plan for you that's unique to you. But we're not there yet. These are viable. These are appropriate. We just have to be a little more cautious and specific and deliberate in how we use them.
And that obviously will come with preparedness as well. I mean, just letting the patient know that, hey, like, you don't need 50, you had a knee replacement, but you may, like, telling them beforehand that you're only going to be given a certain amount if you think that there's somebody who's going to benefit from them, and understanding that you only have a limited supply may get them to understand, like, okay, this is, bad, but it's not as bad as I thought. Because I think some people go into the knee replacement thinking that, like, I just had my whole limb replaced, this is going to be crazy, I'm going to need like 50 pills for me to get over this pain.
Yeah. So again, that speaks to education, engagement, expectations, right? If you do a good job with that, then I think their anxiety goes down, their fear goes down, the misconceptions go away, and they have a realistic understanding of what's going to happen.
Now, the idea is great, right? Like, we want to make sure that everyone's prepared, and, we want to make sure the patient is on all fronts, like, ready to go. But what's it been like going through the process of idea to implementation? It's certainly one thing to have an idea, but to implement it is completely another. What has your experience been like trying to implement this plan and protocol?
Yeah, it takes time, it takes buy-in, because there's a certain culture that gets ingrained. You've been used doing it this way, and I agree. The nurses, for example, were very hesitant, right? Because they don't want to see patients in pain, and and they want to be able to deliver kind of the most caring care that they can to their patients. And so, it shows, all right, we're, for example, length of stay, right? When I went from, just like everybody else, right? Patients were staying in the hospital 3, 4, 5 days, and I got to outpatient total knees. First we dropped down to 3 days. Okay, everybody good? You ask the therapist and the nurses and everybody, yeah, all right, 3 days good. All right, we're dropping down to 2 days. Okay, so we send the patients home day 2. Everybody good, right? You do that for a while. All right, we're going to go to 1 day now. Everybody good, right? So everyone buys into it. They see the results. You don't go from 4 days to 0 and just kind of blow everybody's world up, right? So it's that crawl, walk, run. And then eventually the big flipping point was when it was day 1 and we switched to day 0. So I said, hey, I think a lot of these patients could go home the same day, don't you think, Mr. or Mrs. Therapist? Like, yeah, you know what? A lot of these patients probably could have gone the same day. Are you ready to do that? No, I think, let me. And so, so slowly you get everybody's buy-in, right? The nurses like, yeah, I think I get it now, Dr. Dasa. I see what you're talking about, right? Yeah. And I pointed out, right, this patient I think could have gone home yesterday, don't you? Like, yeah, you know what? Yeah. Then all of a sudden, all right, everybody ready? We're gonna pull the trigger. I got a couple patients, they want to go home the same day. Boom. Right? Did the sky fall? No, the world kept turning. Patients did well. And here we are, right? We're now doing outpatient total knee replacement. So same idea with opiates and everything else. Again, the team has to buy in. It can't just be you being a dictator saying we're going to do this, because you're just going to expend a lot of time and energy fighting. So you have to show people the path forward. You have to be a leader, right? I mean, that's what leaders do. They get the buy-in of their team to kind of implement and execute on your strategy. And so that's essentially what the surgeon needs to do.
Well, you've certainly implemented a level of patience that most may not want to admit will take in order for to implement a process. Was that something that you had to practice throughout your implementation of this new protocol?
It takes patience, right? I mean, if you really want, but they're all incremental. You change one thing, all right, cool. It's not like I came with this whole spreadsheet of 50 things I want to change all at once. You tweak, and then you iterate, and then you get to where you want to be. But you need to have a goal, right? You need to have a finish line. What is is your goal as a surgeon just to bang out a bunch of cases every day and go home, or is there a clinical goal you're shooting for? Where are you trying to go with your surgeries, other than just showing up and doing a bunch of surgeries, right? And so I think that's a lot of physicians, I don't think, have that end game. Like, what are you trying to accomplish? And so for me, it was, how do we deliver opiate-free outpatient total knee replacement with kind of enhanced recovery, fastest recovery possible? So what are all the things I need to think about? I need to think about quad strength, right? I need to think about pain. I got to think about how I close the incision. You got to listen to your patients. My patients were telling me I couldn't get the flexion I want because every time I got to 90, the staples would pull. And I can't tell you how many patients said, I think I could bend more than this, Dr. Dasa, but the staples really bother me. I'm like, all right, well then can I get rid of the staples? Right? So, but you have to listen to your patients. You have to pay attention. What are the barriers that are prohibiting you getting to that end goal? So if it's range of motion, all right, what are the barriers to getting to whatever range of motion you want? You have to sit there and kind of think, and talk to your therapists, right? And talk to the nurses, or whatever that clinical endpoint is that you're trying to achieve. Who are the stakeholders involved in that, and get their opinion and work with them to find the solution.
Was this idea of identifying and clearly stating what the end goal was something that naturally came to you, or was that something that you had to adopt, or maybe you learned from somebody else?
No, I mean, it's just kind of just evolved, right? And so how do I, it all started with length of stay. When I wanted to start doing outpatient total knees back in 2013, no one was doing it, or very few people were doing it. So I said, all right, how do I get there? Right? So what do I need to do to get there? Because that was what I wanted to do. I wanted to get there. All right. So part of the biggest issues was the anesthesia, right? We're doing femoral nerve blocks and their quads were given up. So I can't do much until they have quad strength to get you home. Otherwise, I'm sending you home with a knee immobilizer, right? So then how do we evolve regional anesthesia? And then we started doing adductor blocks. Then, the posterior capsule block, IPAC block. And so, but the goal was, I want an outpatient total knee. I want to get there. I wanted this surgery to be no different than an ACL.
And I was going to say, that goes without saying, even for the patient itself, right? Identified what their end goal is with this knee replacement. And have you tried to implement that as well with the protocol?
Yeah. I mean, part of the challenge is when they're doing this well out of the gate, their expectations start going through the roof, right? And so you got to dial that back. You still have knee replacement. This is not, some little dinky surgery. So, so that's another challenge that comes with the territory as you start doing these things.
So overall, what would you say would be the best way patients can prepare both mentally and physically for a knee replacement, and having done so much work in this area?
I think really you got to talk to your surgeon. I recommend all my patients go talk to my therapist. I actually tell them, especially the ones that are a little hesitant or a little nervous, I say, listen, go knock on the door for our therapy office. Just tell them, I'm thinking of having surgery with Dr. Dasa, and they will sit down, they'll explain everything to you. And then hopefully there'll be some of my patients there doing therapy at that time, so you can see for yourself. Because I can sit there and explain it from a surgeon's perspective, but I said it's really different when you go and actually see and talk to the folks that are going through it. So I think educate yourself, talk to some patients, talk to the folks that are kind of in the trenches after the surgery, so you have a true understanding of what it's like.
Well, I would say the theme of our conversation is being collaborative and collaborating with many different disciplines, whether it's patients collaborating with patients, physicians collaborating with therapists, and so on. Another area that you kind of want to help to change healthcare is through the genesis and the creation of the social platform for healthcare providers. And this platform is called Doc Social. And I kind of want to get, perhaps describe what your mission statement and your experience with creating this new platform is.
So we originally created this platform. Alok Sharan and David Flickinger were trying to figure out kind of what the next evolution of medical education would be, as we head into this virtual world with COVID and everything else. Then I came on board and said, hey guys, I think there's an opportunity here to expand this. Why do physicians have a monopoly on knowledge and education? Why can't we engage everyone in healthcare, nurses, therapists, pharmacists, whoever? So can we create a platform that has everyone at the table, not just doctors learning from doctors? And also because healthcare is moving to this more collaborative approach, right? It's decision making is now a team sport in healthcare, especially large decisions. It's the VAC committee, it's the P&T committee. It's not just me pounding my chest saying I want this drug or this device. So if we want healthcare to move forward, everyone's got to be on the same page as the surgeons, and we have to be on the same page as everybody else. So I think this is an opportunity to create a platform to have all of healthcare kind of learning together. If you look at the typical platforms that are out there, they're very siloed, right? Take Doximity, for example. It's only doctors. Well, that's not going to get us very far if I need to work with nurses and therapists and pharmacists and all kinds of people. It can't be just doctors talking to each other in an echo chamber. And so that's where this platform came from, is how do we get everyone in healthcare to interact with each other so we can tackle some of these bigger issues.
One of the bigger issues with these platforms, as well as social media more broadly, is the ability to identify and decipher between valid health information. How can providers and patients decipher on Doc Social and maybe other platforms what is valid, health information?
Well, I would hope if it's coming from a physician or from a provider that it's got some validity to it, right? If the physicians, who else can you turn to if the actual doctor
right.
Doesn't have the information? So this is not necessarily a platform for some random person to come on there and espouse some weird. And so the beauty of the platform is you have other professionals in this space that are policing it, right? You've got all these other physicians and nurses and therapists and whoever. So it inherently has that validation in there that hopefully the information's true and accurate. And you can see how people respond to it. I mean, if all the physicians are replying to something, they're saying this is garbage, well, you may want to think twice about believing, whatever it is that's on there.
Certainly. And I'm assuming you face challenges along the way of becoming, growing this platform. I guess what has been the biggest challenge for you trying to create a platform full of other healthcare providers?
I think it's just awareness. Because when people go to the platform consistently, we get really, really nice feedback about, this is a great place for us to all meet and all that kind of stuff. So, just like anything else, all these platforms, we're getting pulled in a gazillion different directions. There's a lot of noise. And how do you figure out and decide, what's right for you? And so this is not a platform for kind of just very effervescent conversation. So I look at Twitter and LinkedIn and all these other platforms where they're in a way like screening tools of information, right? So what are topics that may be of interest? Because what happens is you don't have a place to have a deeper dive, right? If you look at LinkedIn or any of those platforms, you blink and it's gone. The post is gone, right? Yeah. It's moved on. So let's say there's a topic, let's say on opiate use and reducing opiate use. You could post something on LinkedIn, and the moment you turn away, it's gone. And then that idea that concept is lost, right? So let's move that conversation off of these traditional platforms onto a platform where, there are a group of people that really want to do a deep dive on that topic. Come over to Doc Social, at least from the healthcare perspective. So all these other platforms are extremely beneficial because it allows you to process a lot of information quickly. But for the topics that really resonate with you, then let's move it over to a platform where we can have that deeper conversation and roll up our sleeves and learn more about it.
And collaborating with other healthcare providers certainly has to make you kind of bring your A game. Essentially, you want to make sure you've done the research, you've done the backup work to make sure what you're talking about, you know what you're talking about. Essentially, I suppose, how has creating this platform made you a better teacher and perhaps a better mentor for your students and other providers to look up to?
Yeah, I think it's forced me to kind of understand how to present data, present information in a succinct and easy to understand way. Because I think typically as a in an academic medicine and you're writing research papers, there's a tendency to have a lot of fluff, right? So how do we get the core piece of information in a digestible and high yield manner to the learner or the end user? And so I think that's what these platforms have enabled me to hopefully do a better job with.
Well, I'm certainly excited for the future of Doc Social. I kind of wanted to get your opinion on what you're most excited for with the future of healthcare.
What am I most excited for?
Yeah.
I think it is the technology evolution that we're seeing. So can we start handling much more complex concepts and data in a way that is actionable? So for example, robots in the OR, are we going to be able to do new procedures and new things in a way that I can't do as a human, and then lead to new implants and new innovations, and maybe we come up with a cool new implant because the robot can do something differently? Or in the office, can the EMR or some of these things process so much data so quickly where it gives me a game plan, an individualized game plan, helps me synthesize all that information? So for example, opiate use, right? Where I take all these parameters and it tells me, all right, this person, you don't need to prescribe 50, you only need to prescribe 3.7 pills, right? That's what I'm hoping for, that we're getting to this point where technology can really be meaningful, not just a burden to us, but actually a tool that's helpful.
Yeah, and hopefully provide some clarity on some of the unknowns and maybe some of the guesswork that a lot of providers do. I know in PT, there's a lot of that as well. And so hopefully we can start getting some objective data and make it visual so that way people can really understand what we're actually doing correct.
Yeah, actionable. That's the key word, I think.
Well, I'd like to thank you for coming on the podcast today. I really appreciate it. And as a way to close out our conversation today, we will close our episode with the Health Me to Health You portion of the podcast with 3 final questions that I ask all my guests on the podcast. And of course, today is no exception. Are you ready, Dr. Dasa?
Sure.
All right. If you had the attention of everyone in the world for 30 seconds, what would you say?
I would say we have to do a better job of creating a level playing field for all comers and deal with inequities and health disparities in a way that's meaningful.
Couldn't agree more. Second question, what book do you recommend, whether a book you're reading now or in the past?
Resiliency. So there's a book on how to create resilient systems. I forget what the author is. And so that was a real eye-opener for me to understand whether it's nature or even drug cartels, for example. They're extremely resilient organizations. And so how do you create redundancies and resiliencies so whatever it is you're building doesn't fail?
Interesting. Well, and in the show notes, the book recommendation will be down there. So just be on the lookout for that. Last question, where can people learn from you or find you on social media as well as Doc Social?
Yeah, so on LinkedIn is where I spend a lot of time. So you can find me there. On Twitter, I'm there as well. And then Doc Social, doc.social. You can find me there as well.